Well, hello. Welcome, everybody, to the Research Roundtable. My name is Kyle King. I'm a junior at Yale University studying neuroscience with a particular interest in OCD, not only because I think the disorder is interesting, but also because I have it. So a lot of the research that comes out is really relevant and personal to me. And thank you all for tuning in. We did not have a show last month, so there's been a bit of a hiatus, and that was just because last month was OCD Awareness Week, like dead in the middle of it. So me and John both took a break to focus on our own little advocacy adventures. But if you couldn't tell from what I just said, a lot of my personal details have not changed in the last month. I'm still Kyle. As always, I'm joined by my co-host John. John, if you'd like to introduce yourself.
And I'm still John, still a professor at the University of North Carolina, clinical psychologist, love studying OCD and learning from people who have it and treating them, hopefully, and learning from the awesome folks that we have on our roundtable today. Let's get to them.
Yeah, and John, I would also like to say that this is our anniversary.
Happy anniversary, Kyle.
Yeah, I'm sorry I forgot to get you a gift. I know.
You know what? I forgot.
I'm a bad live stream husband. Yeah, this is our year anniversary, which is pretty cool.
Wow.
So
yeah.
as you can see, we have 3 super cool researchers on the panel today, and we're going to be discussing OCD and schizophrenia and the overlap between these two disorders. And we also might broaden that conversation a little bit to insight in OCD and just kind of generally psychosis and how that interacts with OCD. And before we get to our researchers, I do have some things that the IOCDF will get mad at me if I don't say. So let me make some announcements. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org. You'll also notice, if you're tuning in, that we have a chat feature. And we want you to know that you can use this chat whenever. We love when you ask us questions, and we're going to try to get to as many questions that you guys ask us live as we can. But also, we want this chat to be a really safe space. So please be kind and respectful when you're using this chat feature. Everything you put in there will live on the internet, on YouTube, Twitch, Facebook, forever. So just be mindful of what goes in there and don't be mean to each other. But throw in your questions. Okay, so enough of that talking. Let's get to our speakers. So I'm going to start with the first person on my bio list, and that's Dr. Jen Buchholz. Dr. Jen Buchholz is a clinical psychology postdoc fellow at Stanford University School of Medicine. She received her doctorate at the University of North Carolina, Chapel Hill, where she studied the development, maintenance, and treatment of OCD and anxiety-related disorders under my co-host, Jon Abramowitz. Dr. Buchholz is especially interested in identifying the most effective and efficient cognitive behavioral techniques to optimize and improve access to treatment across diverse populations. She has experiences working with individuals with OCD and co-occurring diagnoses and regularly integrates ACT, inhibitory learning theory, and couples and family-based approaches with exposure therapy. Jen, how you doing?
I'm doing great. It's so awesome to be here. Thank you for organizing this wonderful panel.
Thank you for being on it. Would you say you're excited or excited to see John again, or you've seen him too many times and it's bringing back bad memories?
Oh, great question. Very loaded question. Just kidding. I'm so excited to see you, John. I miss the days when we got to hang out almost daily during grad school. We had so many fun discussions about OCD and how we can improve its treatment.
Agreed.
Next on my list is Dr. Emily Becker Haimes. Emily Becker Haimes is an assistant professor at the University of Pennsylvania Center for Mental Health. She is also the clinical director of the Pediatric Anxiety Treatment Center at the Hall Mercer program, which is the only specialty anxiety clinic in Philadelphia dedicated to serving youth in the public mental health system. She is an implementation scientist and a clinical psychologist whose work is dedicated to improving mental health services quality in specialty mental health settings for youth. She has expertise in the implementation of exposure therapy across settings and the application of exposure therapy for youth with complex comorbidities. Emily, how are you doing?
Great. Thanks for having me here. I think one thing I also just want to add, but I'm particularly excited to be here today, is I've had the privilege for the past couple of years to partner and collaborate with the coordinated specialty care programs in Pennsylvania for first episode psychosis. So this is an area that's really interesting to me. And I think there's a lot of need to have a lot more conversations about how to approach the overlap with OCD and psychosis. So thanks for having me.
Yeah. And kind of touching on that, like there's a need to have this conversation. Honestly, when Jon pitched this live stream topic to me, I had no idea that this was even like part of the literature, and reading it was really interesting. But yeah, that it kind of speaks to just kind of the lack of spotlight on this topic. And someone who is also spotlighting this topic is Bob, Dr. Robert Hudak, who's on my right. So Dr. Hudak is an associate professor of psychiatry at the University of Pittsburgh School of Medicine. He graduated the Northeastern Ohio University College of Medicine in 1992 and completed his residency in psychiatry at the University Hospitals of Cleveland in 1996. He then joined the Cleveland VA Medical Center, where he formed the OCD Clinic for Veterans. He became full-time faculty at the University of Pittsburgh Medical Center in 1999. And in 2000 became the medical director of the Center for Treatment of Obsessive-Compulsive and Related Disorders at Western Psychiatric Hospital. He's also a member of the IOCDF and is the co-chair of the Special Interest Group for Treatment of OCD with patients with autism spectrum disorder, as well as a member of the Scientific and Clinical Advisory Board. He is the current co-author of Handbook of Psychiatric Disorders in Adults in the Primary Care Setting. He lectures on OCD in numerous universities and community settings across the United States, and has given numerous interviews in the popular press, both local and national, on OCD topics. So Dr. Hudak is certainly an authority in this field. And I would ask you how you're doing, but I don't want to repeat the same question 2 times. So do you like The Simpsons a lot? Is that like your favorite TV show? Is that a Homer Simpson, like little caricature I see in behind you?
It's a little Homer Simpson wind-up doll, and behind me is a cartoon cell from the season 5 Treehouse of Horror episode. I got that many years ago.
Huh.
Okay, that is my favorite TV show by far.
The Simpsons, nice. We should say that Bob is also a wine connoisseur.
Oh, that's why you made that wine reference earlier.
Yeah.
Is it true that Jon, you and Rob have never met each other?
No,
no, that was a joke. I was like,
there's no way.
I was introducing myself to Emily. I've not met Emily before, but Jon and I have sat down and had dinner and wine many times.
We sat, most recent being in Denver at the OCD Foundation conference.
It didn't make sense to me, but I forgot to ask backstage, so I wanted to ask in front of everybody.
Now everyone knows.
So so we're going to be talking about OCD and psychosis, schizophrenia. And since this is a live stream with the IOCDF, we oftentimes kind of jump into these conversations with the presumption that people know generally what OCD is. But when we're talking about a comorbidity, I don't think it's fair to assume that everyone knows like what we are talking about with psychosis or schizophrenia. So I wanted to start at the very beginning with just kind of 2 basic definitions. If someone would help me out, what is schizophrenia? Kind of like what are the clinical characteristics of this disorder, and what is psychosis?
Okay. I'll start out and describe schizophrenia. And so schizophrenia is not what is popularly believed, that it means a split personality. Schizophrenia, it's thought of as a break from reality. There are 3 aspects of the diagnosis of schizophrenia. 1, the patient suffers from delusion. A delusion is a false fixed belief. In other words, they believe things that aren't true. The second thing is hallucinations. Someone with schizophrenia will have false sensory perceptions. They're usually in the form of auditory hallucinations, so often in the form of voices, voices talking to themselves or talking to each other. The third aspect of schizophrenia is what's called thought disorganization. Their thoughts don't work correctly. They don't measure. They don't mesh, and they don't go in a linear fashion that other thoughts do. That other people do. And to give you a quick example of that, I was once interviewing a patient. I asked him how he was in taking his medications, and he thought for a second, and he said, "Is that related to carrots in the field?" So again, that's called a loose association. It's just the thoughts just simply don't flow correctly. And those are the three things you need to diagnose with schizophrenia. There is a fourth aspect of schizophrenia that's not necessarily required for diagnosis, but they call it negative symptoms, where the patient is very withdrawn, very inactive. You'll see very little expression on their face, and are very content to often just sit around and be by themselves and do nothing.
Okay. And those first three kind of groups that you mentioned, are those all required for the clinical entity of schizophrenia for a diagnosis?
You need to have one of those three things to be required for schizophrenia. Many patients will have all three, but you need one of those three.
Okay.
And there used to be different types of schizophrenia, right? In older versions of the DSM, paranoid, undifferentiated, but we've done away with that. The DSM folks have done away with that in the most recent iteration.
And the reason for that was because you could, those subtypes were, you could see patients that really fit those subtypes. Over time, longitudinally, people would drift from one category into the other.
Interesting.
So the delusional aspect is interesting, and I think it's going to come up a lot maybe later. If the little plan that I had for how this talk might go is stuck to, which it doesn't need to. So like in schizophrenia, what are some like general, are there delusions that are more common, I guess? Are there common categories delusions tend to fall into?
I guess I'll keep answering this.
Anyone can.
Yeah. I mean, delusions can be about anything. Certainly there are common delusions. People believe that, people are out to get them. They'll believe that, the FBI is out, after them. There are various categories of delusions. There are things we call grandiose delusions, where people may, for example, believe that they have special powers or believe that they're reincarnated as Jesus. There are paranoid delusions where people have these large, systematized, long-standing type delusions. So, I mean, there are categories of it. Similar to what we have in OCD, there are different categories of delusions that you can get. But as far as what a delusion is about, a delusion can literally be about anything.
Mm-hmm. That's what I was kind of getting at, to see what the similarities were between categories of delusions, maybe, and categories of like OCD content. And then if someone else would want to explain what psychosis is.
Sure, I'm happy to jump in. And thank you, Bob, for starting us off. I would say psychosis is less specific as far as diagnostic requirements or diagnostic criteria as with schizophrenia, and can be seen as an experience or even a symptom that can have various causes. And so often, if we're thinking about OCD and psychosis, it may not be someone who meets full criteria for schizophrenia or another psychotic disorder, but is experiencing this kind of disconnect from reality, which can include hallucinations, delusions, like Bob said, but less about specific criteria. And folks can have one psychotic episode in their life, one of these experiences of psychosis, or several throughout the course of their life.
Mm-hmm.
And I think one other term I would add, just to add to sort of the lexicon, is also, especially for those working with younger individuals, is the clinical high risk group, which are people who may not have full-blown symptoms of psychosis, where there's a sort of clear departure of departure from reality or perceptual disturbance, but a collection of symptoms that seem to indicate some sort of change in symptoms from baseline, often potentially maybe other signs when there's family history that may make you more concerned for the particular pathway that an individual might experience. And sort of classifying or conceptualizing someone as clinical high risk can be really important to getting people into care as soon as possible if they go on to develop sort of more full-blown psychotic symptoms like Jen was describing.
Mm-hmm.
As a physician, I like to say it this way: diagnosing someone with psychosis is kind of like diagnosing someone with sore throat. It's really a symptom. It's not an actual diagnosis per se.
Okay. So, yeah. So, oh, John, I don't know.
Oh no, I was just scratching my nose there.
Okay. So I guess like the big question then, now that we got kind of the definitions out of the way, is what is this overlap between schizophrenia and OCD that John said would be interested in talking about? Like how connected are these two disorders?
Yeah, I can start. I think there are so many answers to this question, and I
Yeah,
think
definitely.
yeah, and I think there's kind of the question of differential diagnosis of how do we decide which cluster of symptoms are fitting into an OCD category versus a psychosis or schizophrenia category. And then there's this question about how these symptoms might interact and overlap. And I hope we get to talk about both of those and more today. I'll start by just talking about prevalence. And this is part of what got me interested in this topic, is that, we think of OCD occurring in the population at around 1 to 3%. These numbers are never perfectly accurate, but that's what the research tends to suggest. Whereas in terms of folks who have schizophrenia, the prevalence of OCD is much higher, around 12%, I think. And as many as 25 to 30% of folks with schizophrenia have some kinds of obsessive compulsive symptoms, even if they're not meeting criteria for OCD. And we know that the combination of symptoms end up being associated with a tougher course of the illness, tougher to treat, and more severe symptoms. So just starting there, I think that's one of the reasons this conversation is so important.
And is there kind of like a sense of why that might be? Like is there a psychological rationale for why these co-occur so often?
I think it can be really difficult sometimes for folks to tell the difference. There's some folks who have OCD with, and I think somebody mentioned this before, with like poor insight, right? They really feel like I'm really going to be contaminated. I'm really going to die if I don't wash their hands, to the extent sometimes that it's called like of delusional intensity. Their obsessions are so strongly held that it's delusional intensity. And it's easy in some cases to look at that and see psychosis or schizophrenia. More, I think, psychosis than schizophrenia, because you don't see, in many of these folks, you don't see some of the other symptoms that Bob was talking about, the hallucinations or the negative symptoms. Yeah.
But what you seem to be saying there, John, is that like maybe they co-occur so often because people are differentiating them improperly. But what I got from Jen was like, these are two distinct clinical entities that co-occur often in the same person.
It's both.
Right. I was going to say it could be both.
I have at least 4 patients in my career who are on clozapine for treatment-resistant schizophrenia, who actually turned out that they had OCD. And the reason their schizophrenia was treatment-resistant is the fact that they didn't have schizophrenia at all. And so, they had OCD.
So as someone with OCD and with someone who doesn't know a lot about schizophrenia, but has like this pop culture informed idea of what it is, I have trouble like seeing a situation where someone goes through years of mental health care and they just have OCD and people just persistently think it's schizophrenia. Like, what does that look like? Is it just this kind of lack of insight?
I'd be interested to hear what the rest of you think, but I think there are a lot of folks, it's hard to differentiate. And so there might be clinicians who don't know enough about either one to be able to make that call. And sometimes it's just, I've worked with folks. I feel like I'm well trained to be able to make that call, but I've worked with folks that I couldn't tell.
Yeah. So like in a patient like that, what does it look like?
Anybody else want to jump in?
Yeah, Emily took herself off mute.
Yeah, sure. I mean, I think we know that OCD can present in so many different ways. And sort of, again, to the question of insight, the extent to which sort of an individual feels like they're able to explain a clear link between an intrusive thought and a compulsive or ritualistic act is often one of the things, right, we're looking for when we're diagnosing OCD. And if somebody is sort of describing their symptoms in a way where there isn't a clear sort of ritualistic action, or there's a clear sort of where the thought or the intrusive content is a little bit atypical or outside of what we might typically see within OCD, it can get very complicated to be sure about whether OCD is the right diagnosis or psychosis is more implicated. And this is how I know Jen talked about the overlap being how she came to this work. And I came to this work because I had patients in front of me that I was really struggling to know how to treat, because we had several patients who had both psychosis symptoms and OCD symptoms that seemed relatively distinct of one another, and sort of not knowing, because the literature had given very little guidance of how to approach that, because it is very complicated, especially when there's family history of both OCD and psychosis, sort of genetic risk on both sides. It can be, it's definitely challenging, and sometimes requires longitudinal assessment and monitoring to feel more confident in what's going on for an individual. And to the question around why there's the overlap, I'm not a neurologist and I don't want to speak out of turn about the brain. And yet I do know there are implicated structures that underlie both conditions. And I think one of the ways that we're confident about that from the literature is that there is a decent body of work that would suggest that for certain medications that individuals are put on who have psychosis, those medications can actually lead to increases in obsessive compulsive symptoms within those same individuals. So there is sort of a sense that there is sort of a biological or neurological pathway that may be overlapping between the way these two conditions manifest.
Yeah, and thinking specifically about kind of what makes this difficult to differentiate clinically, I think specifically the differentiation between obsessions and delusions makes a lot of sense on paper and in the research and as far as diagnostic criteria go. And as Emily's talking about, people aren't quite so simple, right? Humans are complex. And so I think—
And wait, I'm just going to stop you 1 second, just so that everyone's crystal clear, because I'm certainly not. The difference between obsessions and delusions being that in obsession, you're more able to explain like where it's coming from, or like, what is the difference?
Yeah, that's a great question. And I think it's not so clear. So in DSM-5, it was actually removed, the criteria that you need to make the link between the obsession coming from kind of your own mind. And that's where this insight piece comes in as well. You know, as Bob was saying, typically delusions, or often delusions, fall into certain categories: persecutory, grandiose, whereas, as many folks here know, obsessions and OCD tend to fall into contamination, responsibility for harm, unacceptable thoughts, symmetry. And that's not always the case. As Emily mentioned, sometimes often, I would say, there are different themes coming up. And so I think that's where it can get tougher to distinguish. And there's, we think too about maybe kind of ego dystonic versus ego syntonic types of thoughts, whereas—
Could you define those real quick?
Yeah, sure. So ego dystonic are common in OCD in that these thoughts feel aversive or inconsistent with someone's identity, sense of self, whereas ego syntonic thoughts have this consistency. So often folks with schizophrenia or psychosis are experiencing these thoughts in an ego syntonic way, that they are okay believing it is consistent with how they see the world. And so that's a helpful way to differentiate, but I also don't think that's always so crystal clear. And to complicate things even more, people can have both obsessions and delusions.
So what if— oh, you go, Bob.
I was going to say, just one more thing that can actually complicate that quite a bit, that's also very understudied, is the role of traumatic experiences as well, can make that diagnosis even more complicated.
I was simply going to say, obsessions can be about anything. And I think a good paper to read on transformational OCD, you can look that up. I think the authors were Buchholz and Haimes, if I'm not mistaken. And they talk about very unusual cases of OCD. And the review paper that we wrote on OCD and schizophrenia, we tried to give a lot of clinical hints for people on how to distinguish between OCD and obsessions and delusions at that point. And it may be worth reading that as well.
So I guess, would it be fair to say that like an obsession and OCD, in my case, I was scared of contamination by like being touched by someone with autism and then contracting autism. So like that's an obsession. If a delusion, as Bob defined it, is just something you believe, right, that like other people probably don't. I believe that to be true, but like somewhere in the back of my head, and I could vocalize this thought, like I logically know this is not true. That's an obsession. And then a delusion is more like there's the sufferer isn't saying, oh, I don't necessarily logically believe this. Like I logically do also believe that I could get autism by touching someone with autism. That's the delusion.
Well, a delusion is just a very comfortable thought that the person has. I'm seeing someone right now in our OCD IOP who has obsessions about being spied upon with cameras and that people are conspiring against her. And it all sounds very delusional, schizophrenic-like, but she is constantly describing it in that ego dystonic way that Jen talked about. You know, for example, she said to me the other day, "I'm convinced that people are spying upon me."
Mm-hmm.
Now, that's not a phrase that someone uses when they're convinced of something. So
is she doing rituals or avoidance or any sort of like neutralizing behavior?
Yes, absolutely.
Okay.
She doesn't recognize it because of her poor insight, but she is doing those things. Yes.
Yeah, which suggests OCD.
Yeah. You know, a delusion is a thought that someone has as comfortable. I'm a psychiatrist. Mm-hmm. And if I had a delusion, that thought is just as comfortable to me as the thought of I'm a psychiatrist. I don't go telling people I'm convinced I'm a psychiatrist. That tells me that the thought isn't that comfortable. So when she's telling me I'm convinced that this thought is true, that tells me she's not really convinced and she's asking for reassurance.
So for a person with delusion, or at least for a delusion, we should say, instead of people, because people can have both, but for a delusion, there's no need to do rituals or avoidance or neutralizing because it's not.
It just is.
Right? There's not, right, exactly, right? This is the truth. And it's like, you know, I know it to be true. And with OCD, we talk a lot about uncertainty because there is that even sometimes just a little bit of uncertainty that makes the person with OCD feel like, what if?
So if I have delusions, though, that I'm being spied on by the government, I mean, I can see myself taking action to protect myself. So how do you draw the line between, that?
Yeah. You're taking action to protect yourself from the content of the thought. You're not taking action to protect yourself from the presence of the thought.
Could you go deeper into that?
Well, you know, so if you have a delusion that the government is out to get you, you may take steps to make sure that doesn't happen. You barricade your door, buy a gun or something. But if you were having obsessions about that, your actions would be to try and get rid of the thought, not the content of the thought that the government is out to get you. In my example, my patient, she's constantly reassurance seeking. Do you think this is happening? Do you think this is really going on?
Right. Mm-hmm. Yeah. Yeah. And there's some sense that why am I thinking about this so much? I shouldn't be thinking about this. I need to put it right. Whereas, right, with the person who has a delusion, they're acting as if it's true. And it's not a matter of putting it right. It's a matter of now you're taking precautions because you know that, you know, or you believe very strongly that this is happening.
And at the same time, you can hear how it feels a little like splitting hairs, and it's really hard to get to that place, which goes back to your point earlier, right? About why does this get misdiagnosed and why is this so hard? And that's a big reason as to why.
Yeah, totally.
Yeah. You go, Jen.
I was just going to add that I don't necessarily think of insight as something fixed. I think, as you were alluding to, Kyle, it can evolve over time and even moment to moment of how firmly someone believes in the obsession. And I would maybe say even the delusion, depending on the person. And so I think that complicates it too. So yeah, I'm glad you mentioned that, Emily, about how it does often feel like splitting hairs, even though we have some nice reasoning behind making a diagnosis.
And I think that's, you know, just as with anything in our field of mental health, you're always going to find an exception, right? Well, as soon as we start to have rules, well, you know, people with OCD do rituals. People with compulsions don't do rituals. You're going to, you know, someone could say, wait a minute, not my person.
And one of the advice that I was given in the sort of diagnostic phase, and I, again, working more with teenagers, more likely to see people in more the clinical high risk stage where it's sort of unclear, is to really mark change over time and look for deterioration in sort of a connection to reality when you have someone who seems to be presenting primarily with OCD, but maybe there's a concern that there's a delusional component to what's going on, that really sort of administering repeated sort of prodromal questionnaires on like a couple month basis, and then monitoring for things like marijuana use that could potentially escalate psychosis symptoms can be really important to track and then connect people to first episode psychosis care if there's sort of a clear deterioration in symptoms and detachment to reality.
So, like, if I'm a clinician or a psychiatrist and I want to make this differentiation, what would you guys say are like some clinical tips? Jon, you mentioned that like behaviors also come into this too, and that could be useful in differentiating the two disorders, which if you get too in the weeds of this delusion versus obsession debate, I feel like it can get really, really complicated, but maybe bringing in all the diagnostic criteria could be super helpful. But yeah, so I guess there's two questions then. What tips do you guys have to make this differentiation between delusion and obsession? And then just the two diagnoses more broadly, what tips do you have to make those two separate diagnoses or just parse them out?
I'll say
Anyone
one.
can start.
So I was just thinking, I appreciated what Jon said before about the compulsion or ritual piece. And I can start with that really finding this functional link between obsession and compulsion can help with diagnosing OCD. Whereas in schizophrenia and psychosis, we do often see behaviors, or as you mentioned, kind of behaviors responding to the content of the thought, but really focusing on how a compulsion might be linked to reducing the distress associated with the thought and the having of the thought.
Okay, that's where I still am tripped up, because if I have schizophrenia, I'm responding to the content of the thought still, and it is reducing the anxiety associated with the thought.
Yeah, I see what you're saying. Go ahead, Bob.
It's you're reducing the anxiety related to the content of the thought, but not the actual presence of the thought itself. There's an author, and I don't know how to pronounce it. Yeah. Okay.
So I'm not trying to get rid of the thought. I'm not trying to
You're not trying to get.
Okay.
Yeah. Let's take another one. Let's take someone who believes that, you know, you know what? I'm not going to be able to come up with a good example because I'm going back to like some sort of persecutory one, and which is, yeah. So scratch what I said. It gets to splitting hairs, and I can see where conceptually, yeah, they're still doing something about it, but it sounds like something Bob said, Kyle, you kind of struck you in a way that made you understand it.
Yeah.
Yeah.
There's an author, and I'm sorry, do not know how to pronounce their name. Oulis. In 2013, I think published a nice guide to think about this, and they wrote 6 points to think of when evaluating a thought. I have them up here. I don't have it memorized, but talks about the conviction of the thought, fluctuation, the fixity of the thought, resistance, awareness of the inaccuracy of the thought, and ability to attribute the thought to an illness. And to use those 6 domains to help distinguish between obsessions and delusions.
Yeah, I think that doubt piece becomes really important. And then the other sort of broadly is that delusions are just one way that psychosis can present, right? So if there are other perceptual disturbances that are also occurring alongside the delusion, like they're reporting seeing things other people can't see, hearing things other people can't hear, that's much more sort of conclusive, right, information that might suggest that there could be OC processes at play and also psychosis symptoms at the same time that warrant attention.
If we can go back to what I was trying to come up with. So anybody know who Andrea Yates is? I think she's still alive.
Yeah.
Right. She's the woman who had postpartum psychosis, drowned her kids in her bathtub like 2000, 2001, like 20 some years ago. And so she had psychosis. She believed that her kids were going to be possessed by the devil and go to hell for all eternity if she didn't kill them right then. And so she did something that people with OCD would never do. She drowned her kids, right? A person with OCD who had that thought would be, you know, are you asking for reassurance? Are you sure I'm not going to do this? They would be avoiding giving the kid a bath. So this woman acted on her delusion because she believed that it was true. That was the example I was trying to think of that I couldn't think of. Does that make sense? Very different.
I mean, isn't like necessary that someone with OCD wouldn't act on that impulse? Like,
Well, people with OCD, when they act, their behaviors are more about getting reassurance because they know at some level that their fear is unfounded.
Yeah.
And they're trying to get that sense of reassurance and guarantee and safety that they're okay. They, at some level, they have a sense that they're okay. If you ask a person with OCD, would you bet me your life savings that you're going to drown your kid in the bathtub? Person with OCD said, of course not. I know I'm not going to do that, but I can't stop thinking about it, and that's the problem. A person with psychosis, you wouldn't want to make that bet.
Yeah. So I guess this gets real quick. Does anyone else kind of have any broad things that might help a clinician differentiate these two? Okay.
And I guess I should say, so even still, we run into trouble, right? Those are some good guidelines, but
yeah,
still not going to work. Like, rules are not always the best thing in this kind of context.
So it seems like one thing that can get really sticky is if you have low insight, it's hard to tell just how much this person is doubting it, just how much this person doesn't is ego dystonic with this thought, doesn't really believe it's true if they have OCD. So I was wondering, are there ways you can build insight in someone with OCD to help them understand that this is something kind of separate from them, to not buy the thoughts anymore?
I mean, that's what good treatments aim to do. It's not easy, but that's what, the idea of, let's just take exposure and response prevention, right, is to teach people new information that they, that they can learn that these thoughts are just kind of nonsense. They're not threats, right? Or that the situation, like touching the floor of a bathroom or something, is not as dangerous as they think. So with repetitive exposure and response prevention, you collect new data to disconfirm the older fear-based beliefs.
So the behavioral work is really what's changing the kind of mental infrastructure.
Yeah, and that doesn't apply in cases of delusions.
Right. I was just obviously just building on what Jon is saying, like even things like sharing information in psychoeducation about how OCD presents, and then really watching, like, is somebody resonating with what you're describing, with sort of patterns of cycles of avoidance and intrusive thoughts and compulsions. And if they're like with you, like, yes, that makes sense, that's me, it's that may give you some more comfort as a clinician too, that OCD is what you're looking at rather than a different type of process. And if that's not, if they're like, that's not right, like, no, like, this is truth, this is what's happening, that may point you in another direction. And I think that it's why you can't rely on any sort of clear, hard and fast rules with this type of overlap.
And you know what, just to kind of dovetail on that, that's a really good point. In mental health assessment, there are times when we don't just kind of do an assessment and say, okay, this is what you've got, right? In many instances, we're continuing to collect data and maybe even trying out treatment interventions and looking at the results and saying, well, if it was OCD, this would have worked this way and it didn't. So maybe that's evidence that it's psychosis. Or we tried this medicine, it doesn't respond. Okay, maybe that's evidence that it's something else. So we're always collecting more data and not being afraid to revise our, conceptualization, diagnosis, whatever.
Yeah, from the perspective of treatment, I am curious what the other folks here think about the potential for building insight. I'm not sure I would necessarily call it insight, but in CBT for psychosis, for example, because I don't have a ton of experience delivering that, but I know that there is an element of reality testing that's often implemented. And so I don't know if we can even be so sure about that we can't build insight in someone with a delusion, but I believe it would probably look a little bit different.
Good point. There are folks in England, Morrison, I want to say Jim Morrison, but he's the guy from The Doors.
Yeah, it doesn't sound right.
Right. That have looked at psychosis and particularly maybe more like the paranoid kinds of delusions, maybe delusions of grandeur, and to some extent hallucinations. They've looked at that from a cognitive behavioral perspective that, we all sometimes get thoughts like, is someone following me? Are they talking about me behind my back? And we all sometimes hear things that other people can't hear. We all see things, right? You have dreams every night, right? And sometimes you hear a song stuck in your head, and we have hypnagogic, hypnopompic hallucinations when we're falling asleep sometimes. How similar are those to the experiences that people with schizophrenia and psychosis are having? And is there more of a continuum with normality than sometimes we thought, or that the DSM wants us to think? I don't know a lot about it.
Yeah, does anyone have any thoughts about Jen's question about building insight in psychosis?
I'm not going to pretend to be an expert in cognitive therapy for psychosis. And I think you're right that I think that is an important component of the work that is done within that cognitive behavioral work. And I think in some of the consultations and collaborations I've had with providers who are more on the psychosis experts, I think one of the challenges, and for me as a child person, right, we often work on like talking back to the OCD and externalizing it, which is probably not what we want to be doing in a psychosis space. So there is an aspect of, on the one hand, yes, we need to monitor and check things over time and be okay with the uncertainty sometimes of not knowing what the official diagnostic presentation is. And an element of, when we are uncertain, really treading carefully. And like for me, I've had a number of patients now who have both obsessive compulsive or psychosis symptoms, and I still don't want to proceed without consulting and doing a lot of sort of deep thinking and rounds on a case, because it is an area that requires a lot of attention and care and is important and difficult work to do well.
Mm-hmm. And kind of on this like point of treatment, I wanted to ask Bob, pharmacologically, it sounds like drugs for OCD can sometimes make psychosis worse, or did I get that backwards? I forget exactly what Emily said. But kind of what's the approach to treating? Is there a different approach to treating OCD with low insight, or OCD if it overlaps with schizophrenia? Yeah.
Okay, well, yeah. So there's a couple different questions you asked there. So
Yeah, there are.
Low insight in OCD is not related to psychosis or schizophrenia. So I think that's the first thing we have to say, is that insight is not what differentiates obsessions and delusions.
Mm-hmm.
And I think if I can kind of digress from your question a little bit, you had forwarded us a paper from the Spanish group where he was taking a look at the different insight scales into OCD. And what was interesting, there was one scale that separated completely out from the other scales. This is a scale that I'm not actually very familiar with, the SUMD, Scale for Unawareness of Mental Disorder. And it's primarily used in schizophrenia, which is why I wasn't very familiar with it. But it's separated out very differently from the other scales that we normally use to measure insight in OCD. And I was thinking about that, and I think what occurred to me was that when we talk about insight, I think we're kind of mixing and mashing what we're talking about. So in schizophrenia, they talk about anosognosia, which is the lack of awareness that you have a mental disorder. And that is different than insight. When we're talking about insight in OCD, we're talking about insight into specific symptoms. Even I've seen people with OCD, even where they have no insight at all, they still know that they have a psychiatric illness. So I had people who say, you're crazy for touching this. You're going to get sick and die by touching the doorknob. Mm-hmm. You're crazy. I'm sane. However, I have an illness and you need to treat me and get me better. So despite the fact that they have what DSM would call a delusional level of insight, they're actually still, they do not suffer from the anosognosia. They still are aware that they have an illness, OCD. Yeah. It's just the exact opposite with schizophrenia. The people there aren't aware that they have an illness, but they can develop some insight about their symptoms. So again, the idea that paper kind of triggered that thought for me, that when we're talking about insight, there's really two very different things that we're discussing.
Yeah. Okay. So I guess in the OCD sense, when like you still know you have a disorder and you're still saying, hey, treat me, I don't like these thoughts, but I still really believe them. In the case of delusional insight, as the DSM would call it, is kind of treatment protocol going to be different from a pharmacological perspective or from a psychotherapy perspective?
The answer is no. Not from a pharmacologic perspective. There is no evidence that people with low insight respond to SSRIs for OCD any differently than people with high insight. And in fact, there is some literature in the BDD world. So with body dysmorphic disorder, they're actually more likely to have what you call delusional insight. And there is no evidence at all that those patients respond to antipsychotics, for example, and antipsychotics may actually cause more harm than good in those patients. So again, regardless of the level of insight, there's no change in the treatment protocol. We still use the SSRI medications.
Mm-hmm.
I'll allow my August colleagues to discuss how ERP might change in low levels of insight.
Well, it's a lot easier. As if we didn't know that. Yeah, the more that someone has insight, the more they're willing to face their fears, and they're open to learning new information, and it's easier to help them change their minds.
So nothing about the actual treatment model changes, how you approach the first session changes?
Well, I mean, you can do some more education. You can do some maybe cognitive therapy to try to, what's the word we always use? To try to get the person, hey, here's some different ways you might think about it, some different hypotheses, right? And before you try to go in with exposure, sometimes those things work, sometimes not so much.
Mm-hmm.
So, poorer insight is a well-known predictor of poorer treatment response to CBT for OCD. I know it's for adults. I don't know, Emily, if it's also for kids. You see that too, I would imagine.
I mean, a level of insight, I think we look for something a little bit different, and expectations of what 5-year-old insight into OCD symptoms are. It's sort of a whole different ballgame. But to build on that, when there is less insight, often then we work more directly with the support people, right? So commonly with kids as parents, and we're working on accommodations that are in place and pulling back on those to help sort of build insight and awareness and motivation to engage.
Hey, there's a really interesting question that came up. From
questions.
Yeah, from Grace at 12:29. And Grace said, is it okay to offer reassurance to someone experiencing a psychotic episode or schizophrenic symptoms as compared to, in OCD, we want like family members to not give that reassurance for OCD? What do people think about that?
My understanding is that if someone's experiencing more acute psychosis, it is okay to reassure, and especially if somebody's escalated and we want to make sure that we can get them to a place where they can be safe and we want to connect them with help. And there's ways to sort of acknowledge what's going on for them without reinforcing the delusional beliefs, like saying things like, I can see that it's really scary for you to believe what's going on for you, and this must be very frightening for you. I want to help. So it is about reassuring, and also at the same time trying to avoid reinforcing the content of the beliefs themselves. And others feel free to chime in.
Mm-hmm. Well, it's so interesting to hear you say that, Emily, because that doesn't sound so different to me from how we might provide validation. Yeah, that I think in OCD we can provide validation of the emotional experience. We might encourage loved ones to do that for folks with OCD too, but it's not about the content. And maybe there's more overlap there than I
thought. Since we started asking the questions, I don't know how to pronounce this, DLEEUSS 13 at 12:06 p.m. asked, is there any way to shield yourself from insight drops by increasing your ability to cope with difficult emotions? Or will these spikes always occur? And this was kind of dovetailing off of an earlier comment he made that his insight drops when things get hard and he feels depression.
I would just say that it's always helpful to increase your ability to cope with difficult emotions. Those are a part of being human, and the better we are at being able to manage those, that probably helps us to manage a lot of other things too. I don't know if that's specific to this, what we're talking about today.
Yeah, it's making me think that kind of the more folks are willing to practice exposures, practice facing fears, even when insight feels low, even when emotions feel high, the more potent the treatment will be.
And also having self-compassion that some days may be harder than other days, and being kind to oneself when that is inevitably going to occur.
Grace at 1213 said, Jen, your presentation at the past IOCDF conference in Denver was amazing. So a shout out to Jen, of whom I am extremely proud.
Thank you, Grace. And thank you, Jon, for highlighting that, my forever mentor.
This is also an interesting question from Patricia. At 1220, she said, what about a big episode of depression for an OCD sufferer that can lead to an episode of psychosis? Could it lead to schizophrenia? What do studies say? And I think the part that really intrigued me about that was like, what comes first, the chicken or the egg? Like OCD or schizophrenia? Yeah.
One of you want to address that, or?
Go ahead. I'm happy to piggyback and chime in after.
Okay. Well, we're still working on that. I don't think the data is completely clear, but the indications are that schizophrenia can often be preceded by an OCD-like prodrome.
Okay.
So you can start to see OCD, but then the person develops schizophrenia afterwards. As far as this specific question, if you get a major depressive episode, does that somehow lead into an episode of psychosis? Well, you can have major depressive disorder with psychotic features, but does that lead to schizophrenia? The answer is no. It's a separate illness.
Do people with OCD tend experience more or psychosis more often than those without OCD?
That's a good question.
I think that the last data I read is that the rate of psychosis in OCD is like 4%, so not much higher than the general population. Maybe a tad higher, but not much.
Okay.
What is the general population? When I was in grad school, they taught us like 1%. Is that still?
Yeah, it's 1% for schizophrenia, but of course you have to add in, things like bipolar disorder and major depression with psychosis. So other psychotic illnesses are going to raise that up a little bit.
Psychosis a little bit higher. Schizophrenia per se is 1%. Got it. That makes sense.
Mm-hmm. And if someone were to have a psychotic episode, if they have OCD, is that kind of the prodrome you're talking about that's going to lead to, I don't even know if I use that word correctly. I don't know what prodrome really means. Is that going to lead to maybe someone who's at high risk for schizophrenia, like Emily was talking about? Or is there a way to tell someone with OCD might be at high risk for schizophrenia?
So I think that's a good question. And I'm going to say, I think we probably don't know enough to make a firm answer to that question. And that goes back to what I think I was saying earlier about wanting to monitor symptoms over time and looking for progressive deterioration or loss of contact with reality. And I say that too, because there are these coordinated specialty care programs that are designed to help and provide intervention for individuals experiencing first episode psychosis, which have a tremendous amount of support for their effectiveness and putting people on a trajectory to manage psychosis in a way that is sort of sets people up to live the life that they want to live. And those often have limits for how long people can have had untreated psychosis symptoms before they can begin those programs. So in our program, we have sort of aired a little bit more to refer quicker, because we want people to be within their 2-year window of untreated psychosis, so that if they are having psychotic symptoms, that they're being evaluated by an expert and connected to those coordinated specialty care services as soon as possible. Because we have had a few isolated cases where it's been too long. It was unclear, and then at that point they're like, well, these symptoms have been going on for 4 years, so they can have other services, but they don't qualify for that sort of coordinated care. So sort of the nuance of these systems that I think as a clinician who does OCD work is important to be mindful of.
Yeah. I think it's important to point out, we're spending an hour talking about overlap of OCD and psychosis, but as Bob pointed out before, that we're talking about, maybe 4%. That's a teeny tiny percent of folks that have OCD who might also have psychosis. And for the most part, it's really straightforward for clinicians to recognize psychosis. And for the most part, it's really straightforward for clinicians to recognize OCD, overall. We're talking about, when it can be difficult to tease these things apart from each other. And that's a very small percentage of people. I know that there are folks, we would be remiss, I guess, if we didn't talk a little bit about, there are many people with OCD who have obsessions about, what if I have psychosis? What if I had schizophrenia and I've been misdiagnosed? Which, is a not uncommon presentation of OCD. But for the most part, clinicians are pretty good at being able to tell one from the other.
And I would, one place where I've been really interested is, yes, the odds that an individual with OCD will also develop psychosis are very low on the whole. And for individuals who are experiencing psychosis, as Jen said earlier, rates of significant obsessive compulsive symptoms can be as high as 25% of individuals with psychosis. And those individuals tend to have a poorer response to standard treatments for psychosis. So I think there's a real opportunity for people who with expertise in OCD treatment and individuals with psychosis and schizophrenia treatment to really collaborate and think, how can we bring the best of what we know about OCD care with the best of what we know about psychosis care, and really address that very high risk population of individuals.
So it seems like to me, like if you have psychosis, you're going to be at a higher probability of developing OCD symptoms than the probability that you develop psychosis if you have OCD prior. Like, is that what you said?
I think so. I had to play it back in my head.
Yeah.
I think that's correct. Yes, the odds of, if you have OCD, the odds that you will develop psychosis are pretty low, that you would have sort of both. But if you are an individual with psychosis, I think one place where I would love to see more research is among identifying obsessive compulsive symptoms within people who have psychotic symptoms and providing targeted treatment to help mitigate the distress associated with obsessive compulsive symptoms.
Yeah. That's very interesting, and I imagine why that is not worked out fully.
No, it hasn't. Well, one thing I can add about that, we use the term schizo-obsessive a lot for people who are psychotic and have OCD. And I think an important point that needs to be made, in order to be called this schizo-obsessive category, you should meet full criteria for schizophrenia first. Any potential symptoms that are OCD or psychotic, you really need to set aside and not considering those when making a diagnosis of schizophrenia. And only after you make a diagnosis of schizophrenia do you go ahead and then consider, is the person schizo-obsessive? Do they have OCD as well? So in other words, schizo-obsessive is a subtype of schizophrenia. It is not a subtype of OCD.
Okay. And the prevalence of someone with schizo-obsessive is 12%-ish?
I think Jen gave those numbers earlier.
Okay.
Yeah.
So in that population, does treatment change at all in terms of like the cognitive work or pharmacological work?
Well, from a pharmacologic perspective, there is some new data that shows there is a certain genetic change or a gene that people with schizo-obsessive disorder may have. And if you have your OCD symptoms triggered by the antipsychotic medication for schizophrenia, there may be certain medications, and the one in particular called aripiprazole, that may modify those changes and may help reduce the OCD symptoms. So that's probably the major pharmacologic change in those patients.
That's interesting.
And Jen wrote a whole paper on that. She did
Yes. A very comprehensive and good paper, yes.
With Jon and Emily. But I will just say, I think that's why we're so excited to be here today, because or at least I'll speak for myself, but these fields tend to be so siloed and we don't have great treatment recommendations from a cognitive behavioral standpoint or a non-pharmacological standpoint. And so there's some good evidence pointing to CBT and potentially exposure-based treatments too, but we need more collaboration.
So for more info on the treatment question, check out Jen's paper.
Yes.
Well, Emily, Jen, and John's paper.
Mainly Jen. I'm sorry. Maybe Emily was involved, but as far as me, I stayed out of Jen's way while she was working on that paper. She did a fantastic job.
Well, I gotta say, this has been one of the most challenging live streams for me, at least, wrapping my head around everything. The hour went by really quickly. Yeah, Jen, Emily, or John, do you have a link for the paper so Skylar can put it in the comments while I do some wrapping up? But thank you everyone for joining, and thank you panelists for being on today. Again, super interesting. I hope this is not the last time that we talk about this topic or that I run into any of you guys. Just some closing announcements. This live stream is just one of many. The entire schedule of future live streams is on iocdf.org/peace of mind. You can also review the recordings of this live stream and any other live streams on YouTube or on Twitch. And if you need any other resources to learn more about OCD or maybe the overlap between OCD and psychosis, please visit iocdf.org. But yeah, thank you all for tuning in today, and to all our panelists, thank you so much. The link has been put in our private chat. Bam, the link to the paper is in the public chat. Go check that out if you want treatment recommendations on this overlap, and thank you all for coming.
Great intellectual conversation, folks. This was a lot of fun.
Yeah, it was tough. I'm not gonna lie, but
Thank you for having me.
Thank you.
Thanks for joining.